Welcome back to Plastic Surgery TNA. That's Talk and Advice. I am your host, Dr. Earl Stephenson Jr., board certified Atlanta plastic surgeon with over 20 years of experience. And you have landed here, lucky me, and hopefully lucky you. I do this every week so that you can have truth and transformation. So I've been doing this podcast for over a year now and kind of talking about predominantly cosmetic surgery, which is where we are right now in my practice, and we do a ton of cosmetic surgery, but occasionally I do reconstructive surgery. I did a lot of reconstructive or functional surgery when I first started as I built my practice here in Atlanta. And I just wanted to share some of those cases with you for this episode because I really think it's important. Cosmetic surgeons, people who do not have plastic and reconstructive surgery training, will kind of poo-poo reconstructive surgery. They will position themselves as, hey, we're cosmetic experts. That's all we do. So we are the creme de la creme. They may be technically excellent, but being a plastic and reconstructive surgeon is the creme de la creme. We are the surgeon's surgeon. And you'll know what that means by the time this episode is over. So, with that being said, I'm going to share some cases with you. I hope you enjoy them. And I'll tell you why I'm sharing these cases and how that ties back around into why I do what I do currently and how comfortable I feel doing what I do currently. Before we get started with that, let's handle a little business to start. If you are returning, again, always thank you so much. It really helps when you guys like the channel in general, my YouTube channel, and you like the podcast specifically. It really helps build the algorithm. It gets me out in more places so that I can do more things and hopefully at some point be able to really take this platform to the next level. We'll keep working daily to make it happen. So it doesn't happen though without your support. So those of you who are returning, thank you, thank you, thank you. If you're new, welcome. I hope you enjoy. If you do me a couple of favors. Really easy. Click the like button. That helps. Be great if you can click the subscribe button. And then finally, as the trifecta, share this video. Because again, I have tons of other videos that may be of importance to somebody that you know. Maybe somebody you don't know, maybe they know someone else who can benefit from this. So, again, if you're new, thank you for joining me. Like, subscribe, and share. On that note, let's get into it. I'm going to start, as I usually do when I have pictures of real cases. These cases are all mine. I put up a warning, and here it is. So I give you time. I kind of stall a little bit with a little bit of word salad. If you are squeamish, if this is not for you, this may not be the podcast episode for you, but it's really interesting. If you can stomach it, then I would encourage you to kind of see it through because I think, or I'm hoping that you'll have a better appreciation for the training that plastic and reconstructive surgeons like myself have. I'm only going to hit the tip of the iceberg as far as functional or reconstructive surgery, but this is a smattering. And with that being said, it's graphic. We've got incisions and some exposed inner body parts that may not be your flavor. So if this is something that makes you a little squeamish, maybe that you can hang in there and turn away for a second, or maybe you just can glue and dial in. Just remember, no one was harmed in the making or treatment of these clients. So, with that being said, I'll try to put up the graphic content warning as we move through each case. And I have 4 cases I want to illustrate for you today. So, let's get it truly started. Let's start with case number 1. So, case number 1 is a case that I got from a gentleman who probably about 5 years ago walked into my office, said, "Hey, doc, I was wondering if you had any ideas what I can do with this area on my lip. So let's take a look at him. It's a bluish area, and I know you've seen people or may know people who have this bluish area on their lip, their chin, side of their face, top of their head. These are called vascular malformations. And I think this one specifically is a venous malformation. The circulatory or blood vessel system is basically divided into two main types of vessels or tubes that carry blood. There's the tube that carries blood that has oxygen and nutrients to organs. Those are called arteries, and they're under a lot of pressure. They drive blood to various organs to keep them healthy and functional. And then there's a second set of vessels or tubes that carry blood away from the heart, away from the organ back to the heart to get more oxygen. And those are called veins. This particular vascular lesion is a venous or a vein malformation. So it's lower pressure, but still significant. This is a common thing to present in dental offices. You would think, hey, doc, let's look at my teeth. I got this, this purple area. Can you maybe take a biopsy of it? And sometimes, unsuspecting, this is biopsy, and then you end up with a ton of bleeding that's hard to stop. So it's really important that practitioners, medical, dental, otherwise, recognize that this is a blood vessel lesion that can cause a lot of problems if you try to draw the fluid out, puncture it, and drain it. If you try to biopsy, you need to get this in the hands of the right person. And so this gentleman happened to walk into my office and say, "Hey, is there anything you can do about this? I've been dealing with this since I was knee high to a grasshopper. I've not really had any treatment. People have been kind of afraid of it. And so I really want to see if there are any options." So this lesion, this venous malformation of his lower lip on our right, as we look at the screen, but his left involved that side of the lip. It also went inside the lip down toward the gum and a little bit behind the teeth toward the tongue. So this thing is kind of big, and it's not something that you want to remove and disfigure him. It's not something you want to drain and not be able to stop it. It's something that we need to shrink, and so that the body can have a fighting chance by inciting or igniting inflammatory or a healing response to kind of take care of it. So I scratched my head a little bit about this. We talked about it, and I told him, just as I've just told you, that we can't remove this surgically. That's not an option. It will disfigure you. I think there are better ways to do this. So I devised a plan to target the pigmented red cells, for lack of a better term, in the veins of this gnarled up mass. And it's just a gnarled up mass, like yawn of veins that will shrink those veins. It will stimulate the immune response or the healing response to try to clean this up and replace it with more normal tissue. And so I said, it's worth a shot. And then on top of that, we'll try to shrink it down as well. We'll try to shrink it down with a little steroid too. Steroids kind of dampen the immune or healing response. So we're playing a little bit of a balancing game, but steroids can be certainly dampen down something like this vein or venous malformation that wants to continue to slowly grow. So we wanted to balance some steroid treatment to stop the growth, but not halt the healing process that we needed once we hit it with a laser. And that's what I decided to do. I decided to hit this with a 1064 nanometer laser. So what's that mean? It means a laser that's targeted to this red blue spectrum and will really zap and cause an inflammatory or healing response to get rid of this. And I told him, we'll see how it works. It certainly can be better. Don't think it can be worse. And so he was agreeable. So we did about 3 rounds of this, spread out within about 4 to 6 weeks, maybe 2 months between each round. After 3 rounds and a little bit of time, this is where we ended up. Now, he was quite pleased, and I was quite pleased. Bring that up. Let's take that down. This is where we ended up. I'm, I was ecstatic about that. He was ecstatic about that. Now, look, this looks better from a cosmetic standpoint, but it's also kind of prophylactic. And what I mean by that, this will prevent a problem in the future. Let's say he had the original lesion, and he bit his lip in a restaurant. Can you imagine the disaster? Again, he goes to a practitioner who's unaware of what this may be, and they biopsy it. The disaster. This thing keeps growing or growing and growing. It starts to disfigure his lip. He's unable to eat. It starts to disfigure his lip. It starts to crack and bleed and ooze. It disfigures his gums. It causes, swelling of his tongue, which can cause breathing problems. So this thing could get out of control. It hadn't gotten to that point, but it could have. But with the treatment of laser and steroids, with multiple rounds and time and observation, we're able to do a couple of things. Obviously, get rid of the lesion to minimize or prevent those terrible things that I just mentioned. We were able to restore his cosmetic appearance. We're able to restore his confidence, and we didn't need surgery to do that. So, people ask all the time, you know, can you laser my face? Have you done this before? We use lasers in plastic surgery all the time. Or I consider this a reconstructive or functional treatment. We use it for cosmetic treatment to remove certain layers of the skin down to the collagen layer at the appropriate depth to stimulate renewal of the skin with no damage, and to then take care of that controlled, in that instance, burn, because we do burn surgery as reconstructive plastic surgeons, so that you have near flawless healing. So we use lasers, and the use of lasers is not out of our realm of expertise. So that is case number one. Fun fact: 4% of newborns, and this is really terrible for newborns, present with vascular lesions such as a hemangioma, just more kind of the artery type of tangled mess of blood vessels, or a venous malformation, which I think this was. So 4% of newborns present with this. Think this if this were your newborn, what a tizzy you would be in. So the solution, as we talked about for him, we did a precision treatment with laser, minimal downtime. We were patient, and we got a fantastic result. So case number one. All right. Next case number two. Again, a little more graphic. So this is really when you want to turn away. We're actually going to do an operation, or actually did an operation on this lady. So let me set the scenario. The lady was referred to me by a colleague. This was a nurse who worked in his office, who developed this swelling on the left side of her chin that just kept growing, and it was painful, and it was throbbing. And I think she saw multiple doctors, and I think somebody figured out that this case, or this patient, actually had what we call a vascular malformation again, but this was a atrial venous malformation, where we actually have a collection of both the artery type blood vessels and the venous type blood vessels together in a nest. And these are very precarious. They have to really manage these to a T to avoid disaster. So long story short, she got in the runaround. Nobody could really treat it. She didn't really want to go down to the big brand Emory. Want to get it treated in the community. He called me, said, "Hey, Can you take a look at this?" And so I took a look at her. We talked. I told her I thought this is what it was. We've got a bunch of x-rays and imaging, MRI, so I can see what this was. I can see if there had some flow or some, blood flow into it, and it did. And so when I got all the imaging back and had her back for a follow-up, I said, "Look, this is a blood vessel tumor, for lack of a better term, not cancerous, but certainly can cause problems, get bigger. It could ulcerate or crack at the surface and cause all kinds of bleeding. It could grow and disfigure your face and cause all kinds of other destructive problems. We need to meet this head on, but we need to have a plan that includes the following. It needs to include me, of course. It needs to include an interventional radiologist. What I mean by this is a radiologist, like the radiologist that reads X-rays, both broken bones and chest X-rays, but does procedures where he or she can enter a blood vessel, shoot dye to look at your vessels of your heart, place wires or what we call nets in the blood system to catch blood clots before they get to your lungs. So we needed an interventional radiologist so that can map what we call a feeder blood vessel. And it usually has a feeder blood vessel either from the facial artery, which is a branch of the big carotid that feeds this nest. And so I wanted to identify that and see if he could block it, use a little gel foam which is a little piece of gel to just block that artery that's feeding that nest to shrink it. And so the patient was amenable to that. And then once that was done, we'll let it kind of shrink back to a more manageable size. And we know it's not being actively having blood pumped into it, which can make the operation difficult. Then I can go in, remove that clamp and kind of literally tie off that feeder vessel and remove that. And then the threat is over for all the terrible things that I mentioned. So we set that up. We had an op. We got her to the interventional radiologist, who was fantastic. He was able to identify the feeder vessel. He was able to block that feeder vessel, and that lesion of her chin start to slowly go down. The pain got better, and so on and so forth. So a lot of you is thinking, well, why don't you just do that? Just you don't need an operation. You've blocked the circulation. It should just die. No, the body's pretty smart. The body will then just say, well, that route to the nest is blocked. We'll create other routes and we'll create more of them. So we had a window of time that we needed to block it, have it shrink, and then take it out before the body recognizes that that feeder has been blocked and creates more feeders that are more aggressive, bigger, pump more blood. So again, graphic content coming up. This is the patient on the table. On the table. Let me find that. So, all right. So bear with me. I'm going to, again, fire my production person, but it's okay. It's all good. It's all good in the neighborhood. All right. So this is her right in this area. We have this blush of tissue. For those of you who can't see it, it's right on her chin. She's laying on her back. She's anesthetized, asleep, comfortable. This little thing that's sticking out her neck is actually a nerve stimulator because there are nerves to your lip that I need to protect so that you don't end with the Sylvester Stallone lip after the operation. So that's what that is. I have a wiggly line kind of drawn from the corner of her mouth right over that mass that's beneath. Again, for those of you who are listening, just to outline the type of zigzag incision I wanted to make. I did not make a straight incision. I didn't make it I didn't make it horizontal to kind of mirror the border of your jaw. Those are anesthetic incisions. They heal, but they heal with a noticeable scar. I wanted this scar to be zigzag and broken up so that when light hits it, it hits it at certain areas and it's hard to perceive, especially once it's healed after a year. This long line that you see at the bottom here is just outlining kind of the lower border of where I want it to be in case I needed to open her neck widely and tie off something because we had emergent bleeding. So nonetheless, I decided to push forward. Now, she's anesthetized, completely asleep, general anesthetic. Remember, a couple, weeks ago, she's had this area blocked from its circulation, so now it's kind of smaller and more manageable. And so I just made an incision in that zigzag area, and we proceeded to open that up, as you can see here. And for those of you looking, right dead center between those two little hooks and that one thing that's holding, that's my hand, that is the mass of blood vessels. Now, blood vessels don't look like they look like in an illustration or a drawing in real life. It's just a mass, and you just have to know your anatomy, and that's how that looks. So we continued on, and I was able to find the feeding vessel, tie that off, and deliver this mass out of that area. And that will take care of it. Now, this is small compared to what it was. If I tried to do this while this was active, having active blood flow, this would have been a sheer mess. So this was very well controlled. I was able to get this out without incident, and then we were able to close things up very nicely. A little drain to kind of help drain any fluid that wants to accumulate in the space beneath the skin where that mass of blood vessels once was. So, again, got that done. And here she is several months down the road. Actually, I think maybe more like two. You can just barely see that scar on the right side of the screen, which is her left side. And this is probably 2 months, and, in 8 months from now, 10 months from now, you'll barely see that. And she had full function of her lip, no loss of sensation. And so, again, this is something that we do as plastic surgeons as part of functional or reconstructive surgery. Vascular malformations happen only 1.5% of the time in the population. And the most aggressive forms is what she had is an atriovenous malformation. So again, you ask me, how can you do a facelift? How can you do a chin implant? This is why, because I can take care and take care of problems, vascular tumors, remove them and restore normal anatomy. So I can therefore take normal anatomy and improve it. This gives me the foundation and actually the confidence to take normal anatomy that is aged and put it back in the right position. I will challenge any cosmetic surgeon, non-plastic surgeon, to say that experience and experiences like these, taking out atriovenous malformations, taking care of facial trauma, reconstructing wounds from infection, reconstructing wounds from cancer surgery, make me less qualified to do your cosmetic surgery than they are. So again, just doesn't make sense. The solution for this lady again was this was successfully removed with first having a interventional radiology procedure to stop this flow of blood to that nest of blood vessels, and then removing that and improving her appearance. Her pain was resolved. She was able to move forward, and no recurrence or return of that particular issue. So luckily, it was a real interesting case. I was glad I was able to help. And like I said, these are the reasons why we feel confident that we can take care as plastic surgeons, aesthetic surgery. So let's look at the third case. Now I'm gonna have to bring this up because my studio that I use for image holding only holds so many pictures. So let me get rid of some of the pictures that we've already looked at, and let's bring up case number 3. So just hang in there with me. This is a real interesting case too. So let me first do this. Graphic, 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 graphic. So you need some time. I would turn away. I would definitely turn away. So just hold your horses. We're going to take that down. And this lady presented to me from an orthopedic surgeon. Again, remember I said in the beginning, we are the doctor's doctor. The first case was kind of a random case, but he's been to other practitioners and nobody could solve that. We lasered his venous malformation, which is less aggressive. The second case was a lady who had a vascular malformation, more arterial or atrial venous malformation, and she was referred from by a doctor, and we took care of that. This is a referral from an orthopedic surgeon of a little young of an I say young lady, a lady in her 60s to 70s who fell, who hurt her elbow, fractured her elbow, and they fixed it. The orthopedic surgeons did, and the plate was exposed because the wound didn't heal well, and now you've got exposed plate. So the orthopedic surgeons are skilled at restoring the bony anatomy and the function once the bone's restored. They're not trained, let me use that word, to cover wounds, to cover defects, to fill defects, to further enhance the function back to normal. So the orthopedic surgeon said, hey, we got to open exposed fracture with hardware, which are placing screws, and we need some skin over that. And you can't just stitch that together. For those of you listening on the podcast, this is at the tip of your elbow. It's just like a little metal piece sticking through, probably about 4 or 5 inches, covering the elbow fracture. And the wound is probably about 2 to 3 inches wide, and you can't put stitches in that to bring that together. It'll just pull apart. So you need to bring fresh uninjured, healthy tissue in the area. So, where do you get that from? And there are numerous areas to get it from. I decided the easiest thing to do to cover this was to get this tissue from her forearm, from her wrist. And let's walk through that procedure together. So, what I did is I outlined the wrist and I wanted to get a round piece of skin, almost like a little paddle of skin, so that can cover that. And so what I did is we took her to the operating room. We cleaned out the wound on her elbow. I designed my flap. Now, flap is just like it sounds. It's something that can flap in the wind, if we were to use that terminology or that description, where it's connected only at one end. If you think of a piece of skin being connected 4 points of reference, then we disconnect 3 points of reference and leave it connected at one point so we can flap that or move that wherever we need to and pivot it around. So I decided to pivot skin from her forearm on the inside by her wrist. And this is kind of the exposure for that. And I'll explain. So this is me, my assistant. I designed the skin patty. I called it a sausage patty that would cover that wound nicely. But the way that patty is going to live and stay pink and healthy so that it can heal, it needs the blood vessel underneath it. And the blood vessel is the big artery that you feel at your wrist. If you were to just put your 2 fingers on your wrist like this and you feel your pulse, that is the radial artery. And we need to have that artery kind of run right underneath that flap, right underneath that skin, and can provide nourishment up to it. And we need to lift that skin, the artery, and the length of the artery, almost like a little, it looks like a balloon, back to the elbow. And I'll walk you back through that. But before I lift it up and before I cut the artery at the end, right where it joins the palm of the hand, so I can lift up the end and move it around, I need to make sure that before I cut that artery, the radial artery, I don't damage the hand by cutting off the circulation. So you see an X in the middle of the hand, and that X connects the radial artery, which is here, to the ulnar artery in the palm of your hand, like an arch. So if I were to put my finger here and stop the blood flow and put a little probe in that X, I still should hear a heartbeat, for lack of a better term. Excuse me. And if I do, then I'm good. That means I can take that artery, the radial artery, and the blood flow to the hand will be preserved. And so we won't have any damage due to lack of blood flow to the hand. So that's what that represents there. So by having that little blue loop around the radial artery, I can kind of lasso it like lassoing a calf and kink it and stop the blood flow. And then I can use my Doppler, which tests the heartbeat in the hand to see if it's still a heartbeat. If there is not a heartbeat in the hand, then I can't use that. I've got to do something else. And of course, I tested it multiple times before I actually made this cut because it would be silly to make the cut and then realize you couldn't use the flap. But this was just belt and suspenders. So now we need to get this flap of tissue, this sausage patty with its associated blood supply back toward the elbow. So here are the next series of slides. So I've got to now open up the forearm wide open. I mean, wide open. Let's look to the right of the screen. The sausage patty is sitting right here on top of the muscle, and I'm tracing the blood vessel back to kind of at the end of this incision on the left toward my elbow. And I need to lift all that up and keep it alive and not cut the artery and damage it so that I can move the skin from the end of the wrist to the elbow. Look at the next slide. So this gives you a better view once the forearm is open. You can see here I've got my little patty. I've got my two little tweezers, what we call pickups, and these are jurals. They're vascular pickups, so I can pick up arteries without damaging them. I've got the radial artery, and I'm picking it up. And I've got to disconnect all its little feeders to the forearm muscles so that I can free it up. All right, next slide. So here it is being actually picked up. So you can see I'm picking up the sausage patty with the blood vessel. You can see it running right underneath it into it. And I got to pick that up all the way up and take it from here back to the elbow. And that's what we did. Once we did that, then we needed to swing that around so that we can get it close to the elbow. And this is what that portion of the procedure looks like. You can see the patty in my fingertip or on my fingertip, and you can see the blood vessel kind of running toward the arm. Now, I've closed the forearm temporarily. I put in this space where you saw the patty, you can't close that either. So I put a what did I call that? We called it a dermal matrix. And what that means is a fancy word for collagen that will act to close the wound in the forearm or in the wrist. That will allow a surface eventually to take a skin graft. Now I can skin graft directly to that. That you can certainly skin graft directly to that, but to give that skin a little bit more flexibility, pliability to make it move so it doesn't look like it's stuck down. I like to use this intermediate step that gives me a little bit of intermediate tissue between the skin and the tendons in the on the wrist. So that's what we did there. And then we just temporarily closed the lazy S incision. And that's what it is. It looks like a lazy S incision in the forearm. Now that we've got this sausage patty with its blood vessel, and this is a pedicult radial artery flap, we can take that and then use that sausage patty to cover the wound. And this is what that looks like. So I've got the arm held up, and you can see that bone plate is not exposed because we use that sausage patty to put right over that area We stitched it to the area, and we can stitch it to the area because that sausage patty has its own circulation. It's nice and pink as you see here. For those of you listening, it's a pink disc that just covers that elbow, stitched to the elbow, and voila, the wound is closed. And this is an image of the healed wound. Oh, let me, I jumped ahead. This is a close up, the next picture, close up of the forearm. Again, you're looking at the wrist. I've got that dermal matrix, which will be a support or a foundation that gives us some foundation so I can put a skin graft on 6 weeks from now. So that if I put versus putting a skin graft on now without that foundation, where the skin graft once it healed is stuck down and looks like a burn. And I did that too, kind of back toward the forearm where I didn't want to close over my artery. You can see kind of to the right hand side of the skin. I didn't want to bring that skin together and close over my radial artery that now is feeding that little sausage patty around the corner to the elbow because I didn't want to constrict it. So I needed to make sure that that stayed alive at all costs. And here is a picture, final picture of her healed wound. Now, couple of things I would say. This is reconstructive and functional surgery. This is not cosmetic surgery. We got to make the incisions where we need to make the incision. The goal here was to cover her elbow and cover the exposed plate so that doesn't get infected and she doesn't have a bone infection and can threaten her arm. It's not very pretty. It's functional. She can use her arm. She can do everything she can with her arm. She has the the burden of healed incisions that tell a story. That's it. So you say, well, great, that's perfect. So how does that relate back to cosmetic surgery? What are you trying to tell me here? You know, it tells me to tell you that when you ask me, can I do an arm lift? Am I comfortable with removing the skin and fat just to that level? And you're worried about my 20 years of experience, whether I can do that, or if there's a problem, I can recognize a problem, then this is why I can do that. This is why my colleagues who train just like I train can do that. This is why I will just say this as it needs to be said. This is why cosmetic surgeons, someone trained in general surgery, somebody trained in oral and maxillofacial surgery, this is why they shouldn't do that. The moral of the story is everything's great when it's going right. What you pay for is to have someone there who knows what to do when it's going wrong. And so you've seen me lift up skin with the blood vessel, open up the forearm, identify all the anatomy and the muscles and the nerves and keep them safe, lift up what I need to lift up, place it where I need to place it, get it to heal, get the arm to still remain functional. These are complicated procedures. These are tricky procedures. Not that cosmetic or aesthetic surgeries aren't, but these are the building blocks that give me the confidence to do what I do on a daily basis. I have to know the anatomy of every body part, every area of the body. It's not guaranteed that your cosmetic surgeon understands that. If they're a gynecologist and doing your brachioplasty, gynecologists in their basic training don't work on arms, they don't work on legs. We do. So that's why it's important. Fun facts. We talked about the elbow coverage. We just saw that 5 to 10% of orthopedic implants, plates, and screws suffer from exposure. So it requires complex reconstruction, as I said. The solution, as you saw here, was a vascularized, which means it has its own circulation, flap to cover the hardware, restoring function, aesthetics to a degree. But the goal is function versus aesthetics. If we can get both, great, but the goal is always function first. All right. That's case number three. So let's swing to the last case. Let me do a few housekeeping things in my studio because it has some limitations. So we're just going to clean up a few things before we jump to the next case, but I will put up the warning. Graphic warning coming up. This is still graphic. This is not as graphic as the last case. So if you could stand the last case, then you certainly can stand this one. And hopefully I've been respectful of everybody's stomach and all that stuff, and you've been able to hang with me. And if you have, I appreciate that. And hopefully you learn something. So let's pull up the last case. I think everybody's heard stories of dog bites. And this last case is a dog bite case. It's not the most complex dog bite case that I've ever done, but I think it illustrates something that marries kind of what I just said about the elbow. We try to strive for function and aesthetics. And, in these cases, we definitely are nailing down function. And if we can get aesthetics along with the ride, then great. I think this one kind of marries both very well as you can probably can marry those two. So, all right. So let's bring this up. All right. A little blurry. Sorry about that. So, this is a young girl who was bitten by a dog. And this is just not a cut. This is on the corner of her mouth. It is on the left side of our screen as you're looking at it, but it's actually her right side. And it involves a really critical structure, a structure really hard to rebuild. And really you have to be thoughtful modifying it. And I'm gonna put my big face up into place. I'm gonna take this down for just a second. So I really want to illustrate this. We do this. The corner of your mouth, the commissure, this thing right here I'm touching with my ring finger is where the upper lip and lower lip join at the corner. You don't really think anything of it, but it is a complex structure of an amalgamation of a bunch of muscles to give you function, anatomy, shape to the corner of your mouth. As you can see in this young lady, that's been taken out. So, holy smokes, how do we make that more normal? How do we set it at the right level? How do we give it the not right anatomy? How do we position it to have normal function? Really, really important. So in this case, I decided, well, let me back up. When I look at cases like this, I've got a hole. I'll tell my folksy stories here. We plug holes when we do reconstructive surgery. Somebody has a tumor removed by the tumor surgeon and they leave us with a gaping hole, whether that's in their breast, whether that's in their chest, whether that's on their scalp, whether that's in their pelvis, you name it. We got to plug the hole. So, how do we think about that? We think about the structures that are missing in their function. We think about what's the easiest way to do that. And we work along that kind of principle. And I'm going to say this. Can we directly close it? If we can directly close it with stitches, then that's the easiest way to do it. Should we leave it open and let it heal by itself? That's certainly that's easy thing to do. Should we rearrange some of the skin and muscle around the area of injury and kind of rearrange it to close it? That's the next thing we can think of. We can't do that. Do we need to bring in some tissue from an area that's not so close to it? Uh, Example, if I had an arm injury and I didn't want to do a big complex flap like I did from the wrist, I can take a little skin and lift it up from the tummy and then stick it to your elbow and have you kind of hold your elbow in a sling like position. That's uncomfortable. And I've done that a couple of times when I was training for a couple of weeks until that skin from the tummy takes on the arm and we can divide it or disconnect it. Do I take something distant? Or do I take something that's really distant that doesn't have its own attachment, a flap, and bring it in with his own blood vessel, his own artery and vein, and then find an artery and vein in the area of injury and marry those together so that the tissue that I removed, let's say, from your abdomen and brought it up to your scalp, can I connect that back and make it live again so that it will cover the wound, plug the hole, and heal the wound and solve the problem. So for this young girl, I thought direct closure with a little rearrangement of tissue would be a great solution for her. I don't think she needs any distant tissue that's s- has its own circulation but not totally disconnected. A pedicle flap, meaning it's got one end that's stuck and allows it to pivot. And she didn't need a free flap, which is the top of the food chain, the end of the end, where we take tissue from a distant area with its own blood vessels and then plug it in to that area. I thought that we can just use just her own tissue. I think it was just open and just needed to be cleaned, evaluated, and closed, and maybe rearrange some things slightly in the area to get closure. And so that's exactly what I did. I thought that was the easiest solution to the problem. And this is what we got as far as closure. Now, it doesn't look great. It's beat up. It's a bite. It's an avulsive wound. It's like biting into a piece of meat and tearing it off. It's not a cut like a knife. So it's not clean like that, but we get it together. I reasonably get the corner of her mouth together, which is a really crucial anatomic area for aesthetics and function. And we just take out the stitches at the appropriate time, usually about 5 to 7 days. I like to do that. Treat the areas that seem to be a little bit of have a little bit of an abrasion with some thyme antibiotic ointment to keep the area kind of semi-moist and allow for healing. And just watch. And so that's what we did. And this is what we ended up with, which I didn't think was terrible at all, and really required no additional treatment at the time. Pretty decent. As you can see, it's a little scar for sure on the side on our left-hand side of the screen, but she's young. She's probably teens to 20s. I think time will help this as much as anything else, as much as any ointment or salve or treatment, scar gel. Time will help this. Now she can benefit from a scar gel. I like silicone. Silicones, medical grade silicones, have been shown and proven to improve scar quality. But sunscreen, time, I think this will be fine. Most importantly, her anatomy's pretty good. I might actually have even overcorrected a little bit. That corner's up just a teeny bit, but certainly functionally, it's great. No problems. Aesthetically, I think it's really good. You know, it's some can argue it's not a home run, but it certainly is a triple. So, considering where we started from. So, this is a case where we certainly could marry function or restoration of function with aesthetics. And so, dog bites is super common. There are 4.5 million dog bites annually, causing severe facial injuries to the point where, we need sometimes to do the most complex reconstruction where we take distant tissue with its own circulation and plug it into the hole and plug the circulation together to a blood vessel and vein in the neck so we can get that to heal. So dog bites can be tremendous burden in many aspects. The solution for this young lady was much simpler. We just brought the ends together, cleaned everything out, slight rearrangement of the tissue in the area, and I think we've got a nice functional result and a very, very reasonable, at least aesthetic result. So again, it I don't mean to make fun. It's kind of laughable when somebody asks me in good faith. They don't know my background. They just know what I've said I've done. They don't really have any perspective. If you shoot a little Botox here, will that be okay? Yes, I understand the anatomy. I'm going to tread lightly. I'm not going to be cavalier, but I understand the anatomy. I understand the ups and downs that can happen with the treatment. I understand how to approach it. I understand where the muscles are, what I'm trying to affect, and I'll try to only affect that and not affect something that I don't want to uh, have an influence on. Uh, I have an appreciation when people say, "Well, I got these downturned corners. I want to have this." Well, we really can't do that, without some compromise. And sometimes I'm not willing to make that compromise, even though the patient's willing to make it, because at the end of the day, I understand the nuances, and they may not have that same appreciation. So they come for me for my recommendation. I give that to them. And sometimes that is not to mess with that area that is normal but aged, and we're trying to restore it back to a more youthful position. I have confidence to do it because of my reconstructive background. I have the confidence to tell you no, that because of my reconstructive background, we shouldn't do that. Again, I challenge cosmetic surgeons to give me an argument or series of arguments for why that additional, which is basically standard training for us, is not impactful in aesthetic surgery. I just can't fathom a reasonable argument for that. So with that being said, this is why I always champion is a little bit of it's a little bit of self-lauding and applauding. You know, you should go to a plastic and reconstructive surgeon or plastic surgeon, board certified to have your aesthetic surgery. You don't have to come to me. I would love for you to come to me. I think I'm one of the best. I'm not going to sit here and tell you I'm the best. That's being a little bit arrogant. I think I'm one of the best, and I give good service, and I'll take good care of you. But if you decide that you want to go with someone else who's equally trained, or geographically it's just impossible for you to see me, then you go see a plastic surgeon that's board certified by the American Board of Plastic Surgery. No other board, plain and simple. So these are real stories and real cases, and this is why it's so important to seek out that opinion from a board certified plastic surgeon for your facelift, for your chin implant, for your breast augmentation, for your tummy tuck, for your brachioplasty, your body lift, so on and so forth. You get that. If you want to work with me, it's really, really easy. You can just pick up the phone. Here's the number on the screen. It's 770-466-4700. If you're not quite there, you want to scope me out a little bit before you make that call, then that's simple too. There are multiple ways to get to me. You can simply visit my website, www.esjaesthetics.com. You can, I'll give you a little time to kind of let that soak in. You can visit us on my YouTube channel where I have my podcast, many episodes about many things, cosmetic surgery, plastic surgery, and it's always truth and transformation. Or you can look at my other videos that I have on facelift and gynecomastia, so on and so forth. So you can continue to check me out. If you want to kind of go even more remote than that, you're early in the cycle. You want to go to my Facebook page. Certainly go to my Facebook page. Look at my posts. Hear my thoughts. I'm on TikTok as well as Instagram. But if you're already here, you're way down the road. The easiest thing to do again is to call, and we'd be happy to have you come in for a consultation. Consultations are not rushed. We take at least an hour. There is a consultation fee of $225, but that fee is applied to any procedure that we recommend that you decide to move forward with. So eventually, if you decide to move forward with a procedure with us, then that fee is applied to that, and it's essentially a free consultation. So, with that being said, I hope you've enjoyed this episode. I've really enjoyed it. It's just kind of more natural to just present your own cases and just talk, talk, talk. And if you have any comments, questions, or heck, concerns, just drop them in the comments below. I'll try to answer them. Excuse me. But I always appreciate you guys watching the channel. Again, I would love for you to subscribe. I hope so that you'll ever miss an episode. So please subscribe, like this video, and share. On that note, thank you. I hope you enjoy your day, your week, your weekend, and you're safe wherever we are in the world. And until next time, as always, peace.